My talk is on pharmacological management of acute agitation in psychosis and mania. I have no relevant financial disclosures to disclose, or relationships to disclose. And this is the last of my slides that doesn't have a lot of words on it. I apologize, some of them may be difficult for you to read, but this way, if you wish to download them later, you'll have the entire content of my talk available. I also would like to prepare you that I often use the word we in this discussion. That's not a verbal tic or royal we, it's just that I have collaborated on this topic with my friend, colleague, and mentor, Dr. Osser, who gave the presentation just prior to mine. Everything that I'll be talking about today, there I go saying we, everything I talk about today is a product of our shared work. My outline for this presentation is to start with conditions that I won't be discussing. I'll talk about the nature of the evidence, our approach, medication options, comments on delivery routes, both oral and intramuscular, my suggestions for how to choose a medication, and then I'll present recommendations for medications in tiered rankings. And at the end, there will be time for a few extras. So what I won't be addressing are the many causes of agitation that aren't due to psychosis or mania, such as dementia, delirium, intoxication, and withdrawal, anxiety, personality and behavioral disorders, brain injuries, and other medical disorders. Many of those are an entire talk in and of themselves. I also won't be talking about chronic and persistent agitation and aggression, which is a separate and very difficult to treat condition. I won't be addressing medications that can be given via the intravenous delivery route because that's not practical on most inpatient units. And I also won't be discussing many of the older medications. They're known to be effective from clinician experience, older non-controlled and non-randomized trials and anecdotal reports, but rigorous studies are difficult to find. So some words on the evidence. It's difficult to assess. The studies are relatively few. Informed consent requirements are difficult to satisfy in this population and setting. Thus, many studies are unable to enroll subjects with severe agitation. There are also very few studies using oral delivery. And this lack of evidence, I wish to say, is I wish to compliment the people whose evidence we do have, even though the studies sometimes are not the highest quality. Please consider the conditions under which they're trying to gather evidence for us. These difficulties do make it difficult to interpret and compare the studies due to disparate treatment settings, diagnoses, and resources available. They often enroll relatively small sample sizes, sometimes 20 patients or fewer. There's often a heterogeneity of methodology, outcome measures and definitions of efficacy, side effect assessment, medication doses and delivery routes, and comparison arms. There may be none, it may be an active drug, or it may be placebo. The metrics also make this difficult to study. What is being studied and when is it being measured? For example, there's the psychomotor restlessness and hostile attitude measure of the positive and negative syndrome scale, which is a 5-item excitation component of the PANS. There's level of arousal, which can be measured from unarousable through normal to combative and dangerous. This can be found using the single-item altered mental status scale. You can measure psychomotor restlessness combined with level of wakeness and sedation. And for this, we have a single-item agitation and calmness evaluation scale. There's also the clinician overall impression, the single-item CGI. And then response in these studies is measured sometimes at just a single time, usually 2 hours is chosen, but other studies measure efficacy at multiple time intervals. So our approach is to review recent meta-analyses, Cochrane reviews, and published guidelines. We then summarize the evidence, pros and cons for each of the main medication treatments and the recently published interpretations, and then present the recommendations for medication management in tiered rankings based on a qualitative review of the data. This qualitative review does leave room for disagreement, and I don't pretend to be able to present to you the absolute best medication, but I will be providing some guidance for this tricky area. I do want to note that each discussion of the medication and its evidence is going to be presented in alphabetical order, not in order of preference. The rankings will appear near the end. So the medication options, and again, I want to emphasize, this is for acute agitation with a response time frame of 2 hours or less, in alphabetical order. We'll start with asenapine, which may be provided sublingual. The efficacy data for this comes from one randomized placebo-controlled trial. It was industry funded. It used a single dose with no repeat. It occurred in an ED setting with various diagnoses, including psychosis and mania, but not exclusively psychosis and mania. The subject's average rating at intake was moderately agitated. The response was measured at 2 hours, and it was significant compared to placebo, although 7% required a rescue medication. No significant adverse drug reactions were reported, but the data collection for ADRs does not appear stringent. Conclusions are that the sublingual delivery is appropriate for fairly cooperative patients. The efficacy is promising, but this medication needs further investigation in comparison with other oral agents to firmly establish its efficacy and safety. Next, chlorpromazine, which may be given either oral or intramuscular. It remains in use and is often favored because of its sedative properties. However, despite its highly sedating effects, it is not more effective than IM haloperidol. It is significantly less safe than haloperidol. Risks include severe orthostasis, prolonged corrected QT interval, a lowered seizure threshold, and a high rate of extrapyramidal side effects despite its low potency classification. Conclusion is that this medication has been considered obsolete for decades. Next, we have droperidol, which may be given intramuscular. It has well-established efficacy. A Cochrane review about 7 years ago addressed its cardiopulmonary adverse effect profile and efficacy in 6 comparative studies. The efficacy conclusions are that it is as effective as haloperidol, midazolam, and olanzapine in comparison with placebo. There is a safety controversy, at least in the United States. The Medication Oversight Agency, or FDA, the Federal Drug Administration, assigned a black box warning to droperidol 20 years ago due to reports of QTc prolongation risk. The data for that risk are now considered controversial and possibly spurious. The risk was only found at higher doses than usually prescribed for agitation. Prospective observational study of over 1,000 agitated emergency department patients addressed the QTc prolongation controversy. These patients received 10 milligrams initial and median dose. Subject had an EKG within 2 hours of dosing. And I want to just stop for a second and admire the investigators who were able to get EKGs on over 1,000 agitated patients. Only about 1 in 100 patients had a QTc prolongation as defined by a nomogram that they used. And if they excluded patients with other possible causes of QT prolongation, the rate dropped to about 1 in 200. None of these patients suffered a torsade de pointe arrhythmia. The Cochrane review that I mentioned earlier also reviewed these safety conclusions and determined that the cardiopulmonary adverse effect were not more likely than the other active comparison agents. Again, these were haloperidol, midazolam, and olanzapine. and EPS occurred in only 1% of patients. Conclusions there that droperidol is indeed effective and safe, and that controversy has been resolved in the USA. The manufacturer re-released it there 4 years ago. Next up, we have haloperidol. It has been extensively investigated. It is effective as monotherapy. It is frequently used as a comparison in head-to-head and multi-drug trials. It appears to be less effective and has a slower onset than most options other than placebo. There are some risks to consider. Haloperidol monotherapy has more adverse effects than the second-generation antipsychotics commonly used for agitation. QTc prolongation is a concern with haloperidol alone or in combination with anti-EPS agents, but there is little high-quality evidence regarding the severity of QTc prolongation when used briefly for acute agitation. Some authors do recommend requiring a baseline EKG or avoiding haloperidol when the medical history is difficult to obtain or of concern, but others have concluded that there is no significant difference in incidence of QTc prolongation among the commonly used IM treatments. Conclusions: it should not be used without an EPS agent unless no other medication is available. The reported frequency of EPS ranges widely, up to 50%. And acute dystonia is the most commonly seen EPS. One Cochrane review considers the use of haloperidol alone to be unethical due to these very high rates of EPS. A fairly recent addition is ketamine. Rigorous comparative studies are lacking, and analysis of the heterogeneous studies concludes that using an average dose of 5 milligrams per kilogram usually produces rapid onset of desired behavioral response. However, a second dose or rescue med is needed for about 24% of patients. This meta-analysis concluded that the evidence quality is poor and the assessment tools are highly variable and the mechanism of action is uncertain. The intubation rate when administered in the ED is about 2%. Other reported side effects were vomiting, hypertension, emergence reactions, transient hypoxia, and laryngospasm. So this medication has promising efficacy, but further investigation is required. It is not suitable for use in inpatient units due to the risk for adverse respiratory effects. And I'll mention here that when used in the field, the intubation rate is about 1 in 4 patients. It really is risky to use this medication under all but highly supervised settings. Next up, we have lorazepam, which may be given a lot of different ways, but we'll just talk about oral and IM administration. There are no high-quality studies of oral lorazepam for this indication, but at least one major prescribing guideline recommends oral use for cooperative agitated patients and, of course, IM use for uncooperative patients. The overall evidence suggests moderate efficacy for IM administration. The evidence that it induces sleep fairly frequently and quickly might be considered an advantage in certain settings, such as an inpatient unit where an agitated patient is keeping all the other patients awake and stirring them up. The safety findings are somewhat mixed. It does appear to have no adverse cardiac, ventilatory, or EPS effects, but there is a high rate of oversedation. So conclusions are, considering its relative safety advantages, it is a reasonable option for some patients. Loxapine, which is available in a handheld inhaler device, and of course the older psychiatrists in the audience are familiar with using it orally years ago. The USA FDA approved this inhaler device specifically for acute agitation in patients with schizophrenia and bipolar mania. Compared to placebo, a 10 milligram dose showed a significant efficacy at 2 hours, and in fact, it was often seen at just 10 minutes. There were no EPS or cardiopulmonary events noted, but asthma, COPD, and other acute or chronic airway abnormalities are absolute contraindications, And our population does appear to be enriched for these several pulmonary conditions, so you need to be cautious. Sedation and an impaired or unpleasant taste are the most common adverse effects. Another problem is the high cost, at least in the United States. I don't know what it is in Europe. So it is not practical for use in severe agitation due to the delivery mechanism, which requires a fair amount of cooperation from the patient. So it is promising for a narrow patient profile. Further study with an active comparator would help establish its place in our armamentarium. There are numerous studies of midazolam used IM, not for oral. These are done in the ED setting, usually dosed at 5 milligrams per ml. The review of these studies comes to various conclusions. It has a rapid onset of efficacy versus a Cochrane review, which determined that the evidence quality is rather poor and response rate is comparable to placebo. Regardless of that controversy, its duration of efficacy is definitely shorter than almost all other agents, and that short duration of action requires more repeat dosing. Respiratory suppression is a considerable risk, up to 30% in some studies, and that risk is probably at least partially due to the need for repeat dosing due to the short duration of action. I do want to mention that in one study that found a fairly high rate of respiratory suppression, that many of the patients were also alcohol intoxicated. Regardless of the patient population, airway management is required overall in 5% of patients. Again, in the United States, continuous monitoring of respiratory and cardiac function is recommended when using midazolam IM. And this must be maintained until the patient is stabilized. Serious and life-threatening cardiorespiratory adverse reactions, such as hypoventilation, airway obstruction, apnea, and hypotension have been reported. I won't read the rest of that, but the conclusion clearly is that this medication, if it is used at all, must be done under careful supervision. The Cochrane review rates it, and actually most benzodiazepines, as modestly effective, but with poor evidence quality. Next up, we have olanzapine, which is available in an oral tablet, a rapidly disintegrating tablet, and for intramuscular administration. The meta-analyses and Cochrane reviews rate its efficacy and evidence quality highly. A major prescribing guideline also recommends it. Onset is consistently seen within 15 to 30 minutes IM. There is only one high-quality study of oral administration, which I could find, and that measured a response in a wide range of times, from 15 minutes up to 2 hours. The time to onset when given IM is equal to haloperidol plus promethazine, but with a shorter duration of effect. And I mentioned that comparison to haloperidol plus promethazine because that's another of the highly effective treatments. The safety record is good for olanzapine. It is well tolerated. The specific adverse side effects are oversedation is seen in 10%, EPS in a very small number of patients, hypotension likewise in a very small number of patients, and no QTc prolongation has been observed. The package insert does advise against co-administration of IM olanzapine with a benzodiazepine due to the potential for excessive sedation and cardiorespiratory suppression. The evidence for this is controversial, but the recommendation is to wait for at least 1 hour after olanzapine dose before giving an IM benzodiazepine. There's a large amount of high-quality evidence for both efficacy and short-term safety. However, olanzapine does cause significant insulin resistance, abnormal metabolic profile markers, and heightened inflammatory markers after a single oral dose. It is not yet clear if this is unique to olanzapine or also seen in other antipsychotics commonly used for acute agitation. And the long-term impact of the doses typically used for managing acute agitation needs further investigation. Promethazine can be given oral or IM. It has not been formally studied as monotherapy, but one major prescribing guideline recommends it as a lower ranked option, stating a specific indication for benzodiazepine tolerant patients, and I will also add for benzodiazepine seeking patients. The main safety consideration is QTc prolongation. Next up, we have quetiapine, which may be given orally. It appears to have some efficacy for agitation, and it is recommended as a second-line oral option in at least one major guideline. However, multiple studies have demonstrated orthostatic hypotension at a high rate, and paradoxical excitation is seen at a case report frequency. Clinicians do like it in the USA, but it is lightly investigated, and therefore its efficacy and the appropriate dosing strategy is unclear. Next, we have risperidone. It has been considered, or it is considered effective in a recent meta-analysis. It is recommended in a major prescribing guideline. However, a Cochrane review excluded many studies for low evidence quality and concluded that the main outcomes of the included research suggest no real benefit as a treatment for acute agitation. The frequency of EPS is low, 1 in 20, with or without co-administration of a benzodiazepine. There's no information about QTc prolongation when used for acute agitation, but no serious adverse effects have been recorded. Our conclusions are that more quality studies are needed with and without co-administering a benzodiazepine, and these are needed to confirm its somewhat controversial efficacy and determine if the effects of co-administration with lorazepam are additive, synergistic, or indistinguishable. Next, we have ziprasidone, which can be given IM, and oral delivery has not been studied because it's poorly absorbed when administered without food, which makes it impractical for use in acute agitation. The IM delivery is well tolerated with low rates of oversedation and EPS. The IM efficacy results are, however, uneven and generally modest. It is not recommended in a recent major prescribing guideline. Due to the potential for QTc prolongation, the manufacturer recommends consideration of other medications first. Zuclopenthiol acetate. It's often used in the UK and other European countries, but it is not available in the USA. I must rely entirely on the literature here. And summarizing that literature, this medication is effective but has a very slow onset of action. On average, only slight sedation is achieved at 2 hours, and peak effect of behavioral control does not occur until 8 hours up to 72 hours. This compared unfavorably to both oral and IM haloperidol monotherapy. Its unique advantage to other agents is its duration of action, which means there will be fewer doses required to sustain behavioral control. The most common drug reactions are dystonia and rigidity, and my conclusions are that it is not an effective treatment for acute agitation, but has a valuable role for managing patients with fewer injections whose persistent agitation has required many repeated doses of shorter acting agents. Next, we have the medication combinations. Again, these are presented in alphabetical order, not in order of recommendation. We have droperidol with midazolam. There's the major study done by Isbister. It was an ED setting with 3 arms using droperidol alone, midazolam alone, and droperidol with midazolam. The diagnoses were mixed, but mostly alcohol intoxicated. Used a unique primary outcome measure, which was duration of security staff involvement. Secondary measures included the AMSS. The findings were that all 3 arms showed efficacy. The repeat dosing for the 3 arms was 33% for droperidol, 60% for midazolam alone, and 41% for midazolam plus droperidol. Any of the subjects who received midazolam midazolam was significantly less safe due to respiratory side effects. There was a 27% desaturation and/or airway obstruction in the monotherapy arm. It's difficult to compare with other studies due to the unusual metric and subject selection, but efficacy and safety do not favor use of this combination. Haloperidol with lorazepam. This may be given orally, but there are no major studies of this. The IM combination has proponents due to positive older studies, which suggested that the combination seemed more effective than either alone. However, other relatively recent reviews found this combination to have a relatively slow onset of action and be only slightly or no better than monotherapy with either. The rate of EPS was low in these small studies, approximately 5%. More recent reviews concluded that the combination is more likely to produce sedation rather than tranquilization and does not improve the rate of EPS compared with haloperidol alone. Our conclusions are this combination appears to be modestly to moderately effective. The EPS severity is low in our collective experience, but the Cochrane evidence disagrees with that. It is likely to have the same risk for QTC prolongations as haloperidol monotherapy and a similar or higher rate of oversedation compared to lorazepam monotherapy. Next, we have haloperidol with midazolam. Using different time intervals, this combination was judged effective in 2 studies. It was the least effective in 1 study compared to haloperidol, both with and without promethazine, ziprasidone, and olanzapine. And the authors of that study speculate that the short half-life and paradoxical reactions are possible reasons for the efficacy findings. It was the most effective in another study compared with olanzapine, haloperidol plus promethazine, and ziprasidone. Safety and conclusions are that it is not suitable for use on an inpatient unit due to the risk of ventilatory compromise with midazolam. The most common side effects are excessive sedation and hypotension. The rate of EPS in both studies was lower than the comparison drugs. Neither study recorded respiratory events, but screening for this appears to be unclear in both of those studies. My conclusions are that the efficacy is established for ED use only, but it is not clear if it is superior to other commonly used drugs. The rate of adverse effects appears similar or lower than many other drugs. Next up, we have haloperidol with promethazine. It may be given orally, and one major prescribing guideline includes it as an option, but the major studies of this combination all use IM delivery. A rigorous IM study found this combination have inferior efficacy compared with haloperidol plus midazolam or olanzapine. However, a study with similar methodology, one recent meta-analysis, and 2 Cochrane reviews rate it the most effective option as measured by reduction in the PANSS excitation score. A rigorous single study reports a higher rate of EPS compared with haloperidol plus midazolam or olanzapine, but the larger data summary from the Cochrane reviews and meta-analyses reports EPS occur in only 1 in 20 patients. Both agents can prolong QTC, and promethazine can inhibit haloperidol metabolism. This could increase its effect on the QTC interval, and repeat dosing could amplify that risk, but it is not a frequently reported finding. Diphenhydramine is often used instead of promethazine in clinical settings in the USA, but there are no major studies of that combination. So, conclusions. This is possibly the most effective medication treatment when given IM for acute agitation. The safety data is somewhat mixed and unclear, but the rate of EPS in most studies is low. The risk for cardiac arrhythmias is significant in theory, but does not appear to be frequent in practice. Further investigation, although challenging with acutely agitated patients, would be reassuring. Haloperidol with lorazepam and diphenhydramine. This 3-ingredient combination is commonly used in the United States, but I can find no studies of it either. Investigational evidence is clearly needed to establish its efficacy and safety and to support clinical preference in practice. There is potential for added benefit, but also for added adverse drug reactions. Next, we have risperidone with lorazepam. There are a small number of studies reporting good efficacy. The evidence quality is, however, not strong. It is well tolerated. Further investigation is needed to determine if efficacy is due to lorazepam or to risperidone, or if they actually augment each other. Okay, I will now make some comments on delivery, and these will include time to onset, a word on orally disintegrating tablets, and using oral versus intramuscular administration. Time to onset, considerations. So measurements of time to onset are inexact and subjective and determined using a variety of assessment tools. In addition to rating and rater variability, there are multiple factors resulting in significant interpatient variability. There's blood-brain barrier permeability, influx and efflux rates, and within-brain distribution and metabolism. I want to remind all of us that the onset of clinical effect does not equal peak effect. There may be a considerable interval between noticeable effect and maximum effect. I comment on that because people are often in quite a hurry to give a second or third dose, and I'm going to encourage people to wait and let that first dose work. Some words on ODTs. They may be used if the patient is sufficiently cooperative to take oral medication, but ODT absorption is not transmucosal. It still occurs in the stomach. And therefore, the onset of action has been determined for olanzapine ODT to be equivalent to regular tablets. Presumably, this is also true for aripiprazole and risperidone, although that has not been studied. A large observational study of olanzapine ODT showed no advantage in reducing emergent IM use or seclusion and restraint compared to the regular tablets. Speed of onset. So IM delivery may not be significantly faster or more reliable, at least in the context of moderate agitation. The notable exceptions being midazolam and possibly droperidol. 2 studies compared oral risperidone concentrate plus lorazepam to IM haloperidol and lorazepam. A 3rd study compared both oral risperidone and oral olanzapine to IM olanzapine. And an older study comparing lorazepam to haloperidol delivered IM to some patients and oral to others. And in all 4 of these studies, there was no statistical significant differences in onset or efficacy. The IM administration trended towards faster onset, but by 90 minutes, oral and IM administration showed equal efficacy. A recent meta-analysis reports onset for oral olanzapine, risperidone, and loxapine to be as fast or nearly as fast as for most medications that can be administered IM. So considering both ethics and safety, IM should only be used if the patient is too agitated and uncooperative to take medication orally. I'm not going to try reading this table to you, but I have recorded or organized medications by clinical onset into 2 groups, those that average an onset of 30 minutes or less. I do want to indicate that many of these are lightly studied, and that's what the hashtag stands for. So for asenapine, droperidol plus midazolam, haloperidol plus promethazine, I'm sorry, that is in the wrong place, I apologize. Promethazine alone have been lightly studied. And agents with a slower clinical onset, and again, most of these have not been studied well, are haloperidol oral, olanzapine oral, risperidone, and quetiapine. Now we come to how to select a medication. As you have seen or heard, each medication has advantages and disadvantages. The evidence regarding efficacy and safety for each medication is not entirely consistent. So our recommendations are based on an opinion-based qualitative distillation and review of all the data I have cited. And that can be found, excuse me. The basis for this is a paper that Dr. Osler and I published last year, although there are some minor subsequent modifications. In the absence of a single, clearly best medication, our recommendations are presented in descending tiers. Medications that are roughly equivalent are grouped into these tiers and listed alphabetically within their tiers. The recommended dosing intervals are based on the average time to noticeable clinical onset, plus another 15 to 30 minutes to reach peak effect. It may take even longer than this to determine if the medication has reached its maximum effect. Please be patient. Remember that many studies determine efficacy of a single dose at 2 hours. Providers should use their clinical judgment to select within the tiers based on various considerations. You'll know some of these patients from prior experience, and you'll know what they respond to. You'll know if they have allergies or severe adverse effects. You must take into account the medication regimen in place. This is particularly significant when concerned about QTC prolongation. It's helpful to know medical comorbidities, patient preference if known, and there is a small advantage of interchangeable delivery for oral and IM for medications that can be given both orally and IM. If a uncooperative patient becomes more cooperative, you can switch to oral delivery, and if it goes the other way and the patient becomes less cooperative, you can switch to IM delivery. So for the oral medications, tiers 1 through 4, there's high quality evidence is lacking for oral agents due to either study design or limited number of studies. The rankings are largely based on personal experience, field-wide experience, and extrapolation from IM study results. That's not the best way to come to an evidence-based determination of efficacy, but it's the best we can do. So for the oral medications in Tier 1, we have asenapine. It has only one study, but it is studied, unlike a couple of other medications in the oral rankings. This was a single dose given once in 24 hours. Next, we also have haloperidol plus lorazepam, which is best given in a combination of 5 milligrams of haloperidol plus 2 milligrams of lorazepam every 60 minutes with a maximum of 4 doses in 24 hours. Lorazepam can be given as monotherapy, 2 milligrams every 60 minutes to a maximum of 12 milligrams in 24 hours. When this was studied back in the 1980s, the investigators switched to 2-hour intervals between doses after reaching 6 milligrams. We have the loxapine inhaler device, which can be administered once in 24 hours, and then olanzapine, 5 to 10 milligrams every 60 minutes to a maximum of 20 milligrams in 24 hours. Note that olanzapine is metabolized slower in women, and consider spacing doses longer, especially for non-smoking women. A couple of these medications, specifically, the lorazepam monotherapy, there are no high-quality studies. Dosing is based on guidelines or experience. In the second tier, we have haloperidol plus promethazine given 5 milligrams of haloperidol with 25 to 50 milligrams of promethazine every 60 minutes to a maximum of 4 doses in 24 hours. And there are no high-quality studies of this combination with the oral delivery route. Next, we have risperidone, 2 milligrams every 60 to 90 minutes to a maximum of 6 milligrams in 24 hours, and risperidone plus lorazepam, 2 milligrams of each every 60 minutes to a maximum of 2 doses. For tiers 3 and 4, in the third tier we have promethazine alone, 25 to 50 milligrams every 30 minutes to a maximum of 3 doses. This has not been well studied. Quetiapine, 50 to 100 milligrams every 90 to 120 milligrams, 120 minutes to a maximum of 400 milligrams in 24 hours. Again, this has not been well studied. Or haloperidol monotherapy orally, 5 milligrams every 60 to 90 minutes to a maximum of 4 doses. I do not recommend using this alone due to the high rate of EPS. This would be if there is literally nothing else you can provide for the patient. Next, we have the IM medications ranked into 3 tiers, and the strongest evidence quality will be for droperidol, haloperidol plus promethazine, and olanzapine. So droperidol may be given 5 to 10 milligrams every 15 to 30 minutes to a maximum of 30 milligrams in 24 hours. Haloperidol plus promethazine, 5 milligrams with 25 to 50 milligrams every 30 minutes to a maximum of 3 doses in 24 hours. And olanzapine, 5 to 10 milligrams every 30 minutes to a maximum of 20 milligrams in 24 hours. And again, we have the caution about olanzapine being more slowly metabolized in women, and consider spacing the doses further apart. Tier 2 includes haloperidol plus promethazine, 5 milligrams with 2 milligrams every 30 to 60 minutes to a maximum of 4 doses in 24 hours. Lorazepam, 2 to 4 milligrams every 60 minutes to a maximum of 12 milligrams per 24 hours. And this is where it was actually studied. And again, the recommendation there was 2 hours between doses after reaching 6 milligrams. And then midazolam, 5 milligrams every 15 to 30 minutes to a maximum of 15 milligrams to 24 hours. In tier 3, we have droperidol plus midazolam. And I do recommend avoiding this if the patient is also alcohol intoxicated. Haloperidol monotherapy is used as a comparator in many studies, but generally not advised for normal clinical practice due to the high rate of EPS. Promethazine may be given IM, 25 to 50 milligrams every 30 minutes to a maximum of 3 doses in 24 hours, but there are no high-quality studies of that. And there's ziprasidone, which is effective. Well, I hope that's a good luck charm. 10 to 20 milligrams every 2 to 4 hours to a maximum of 40 milligrams in 24 hours and for 3 consecutive days. Again, ziprasidone does have the established efficacy, but the manufacturer downgrades it themselves due to concerns about safety. I'll now finish with some extras. First, comments on dexmedetomidine, which was recently approved for this indication in its oral form, and a brief reminder about non-medication management. So this is dexmedetomidine, trade name IGALMI, is an alpha-2 adrenergic receptor agonist. It's approved for mild, moderate, and severe agitation in the setting of both schizophrenia and bipolar disorder. It comes in an orally dissolving film, which may be self-administered, flexibly dosed at 60, 90, 120, or 180 micrograms. It may also be given IM. Onset is rapid, as soon as 20 minutes. But do note the sublingual delivery route for this new approved version. The patient must be able to cooperate and manage the sublingual delivery, which requires it to dissolve. For bipolar mania agitated patients, it was studied in 380 patients, and within 2 hours, at 120 micrograms, there was an average of a 9-point reduction in the PANSS EC, an average reduction of 10.5 points for the 180 microgram dose, and this compares to a 5-point reduction for patients receiving placebo. It may be repeated in 2 hours to a maximum of 3 doses in 12 hours. For schizophrenia-related agitation, the 120 microgram dose resulted in an 8.5-point reduction in the PANSS EC, and the 180 microgram dose resulted in a roughly 10.5-point reduction in the PANSS EC. The placebo rate, again, was about a 5-point reduction. The investigators rated as responders for the 120 microgram dose about 80% of patients. For the 180 microgram dose, about 90% of patients. And for the placebo patients, it was less than 40% response. As with mania, dosing may be repeated in 2 hours to a maximum of 3 doses in 12 hours. Dosing recommendations are as follows: 120 micrograms for mild to moderate agitation, 180 micrograms for severe agitation, and 60 micrograms if the patient has hepatic impairment. These studies were conducted in patients with mild to moderate agitation, and you should avoid using it in if patients have pre-existing hypertension and syncope, QTC prolongation, or advanced heart block and severe ventricular dysfunction. Following these studies, there was a review in the medical letter on drugs and therapeutics which noted concerns about serious hypertension, bradycardia, and QTC prolongation, finding orthostatic hypertension in about 1 in 6 patients and bradycardia in about 1 in 20 patients. Oral numbness, dry mouth, somnolence, and dizziness are common, and the medical letter concludes less expensive drugs with longer records of efficacy and safety are preferred. Hence, I have not included it in the tiered medication options at this time. Last comment. Please remember to match your intervention with the patient's level of agitation. Attempt non-medication management first, if the patient's condition allows it. If you don't give any medications, there aren't any side effects, there's no iatrogenic risk, there's also less need for staff-intensive monitoring after a medication because there wasn't a medication. If there aren't any holds and restraints which are needed to give IM medication, then there are no injuries to the staff or patient. And if you don't force IM medications, the patient isn't humiliated and traumatized. And I'll repeat my request: if you must use medication, don't rush to administer multiple doses. For those seeking some guidance on non-medication interventions, specifically verbal de-escalation, there is an article from a work group, the Project Beta work group, that was published in 2012 with a lot of really good recommendations and guidance. I will stop here.